So everything that shakes and falls is not necessarily a seizure. So what else could it be? Autonomic disorders, so things that affect your, the way your heart is beating, like cardiac arrhythmias, ischemic heart disease. People who have orthostatic hypotension, that their blood pressures really shift when they change positions, valvular heart disease, drug toxicities, metabolic disorders, sometimes even migraines. Like people will have these like scintillating or obscurations or this visual changes during a migraine. And some sleep disorders. There's sleep disorders where people can just like fall, narcolepsy, or people just fall asleep right away, and that can look like a seizure. There are non-epileptic psychological events. Sometimes they're called pseudo-seizures, where people are manifesting their stress. So anxiety, depression, panic attacks, PTSD, these can all predispose people to looking like they're having a seizure, but it's not an actual electrical storm of the brain. So if someone were to have a seizure, what do? So we talk to them, get their history, because there are some clues, like we talked about with either the myoclonic epilepsy, where people are dropping things, or the temporal lobe epilepsy, where they've had these vague gastrointestinal complaints, the neurologic exam, and then neuroimaging, and then our electroencephalographies. You can have routine EEGs, ambulatory EEGs, or video EEGs. I think we covered most of this. So neuroimaging can be either with a CAT scan, with an MRI with an epilepsy protocol, or a PET scan. So this is a typical finding in mesial temporal sclerosis, and this is what we were talking about with people who have those vague GI complaints who later go on to having seizures. So the temporal lobes are, they're in that corner up there. You can see where it's kind of white. Those are where the temporal lobes are, and that area, when it's white like that, means that there's been some damage or some scarring, and that predisposes people to having seizures. And this is a PET scan in mesial temporal sclerosis, and where the arrows are pointing, where it's blue, that it's not activated in the same way. So there's less going on in that area, and that's also a sign that people would be susceptible to having seizures in that area. So the EEG, it's a test that records the electrical activity of the brain. It can aid in diagnosing epilepsy, tumors, sleep patterns, a lot of different things. So electrodes are placed on the scalp, or in some cases when people are being worked up for potential epilepsy surgery, they actually insert the electrodes deep into the cortex, and you actually get cortical readings. And that's done in the case where you want to take out those mesial temporal structures, and we have to get good information before we just chop out parts of people's brains. So this is what a basic EEG looks like in terms of where they place the leads. An ambulatory EEG, so going back to the routine EEG, it's a 30 to 40 minute study. So you go into the office or the hospital, they put these leads on your head, and they run it for a period of time. They usually ask you to come either the night before sleep, so they want you to be able to sleep during the study. So they say sometimes the night before, try to stay up late that night so we can get awake, drowsy, and sleep during the routine EEG, because sometimes some of these seizure patterns are seen in sleep and not in the awake states. But if you're very suspicious for seizure activity in a patient, and the 30-minute study is not, you don't find the findings that you were expecting, it's just a snapshot in time. So whether you had abnormalities 2 hours before, you're going to have it tomorrow, we can't predict. So in those cases where the suspicion is high, we actually recommend long-term monitoring. So that could either be in the form of ambulatory EEG, where you can actually, they put these leads and then put a cap over your head and you go home with it. And the little Holter, it's like a Holter for your brain basically. and depending on how long the doctor wants you to wear it, you can have it overnight or for 2 days or 3 days. Usually it's anywhere from 24 to 72 hours. If people, for example, you don't know what kind of seizure they're having, or they're having seizures that are related, they have epilepsy and then the medications that you're using is not working, or there's a question of whether they're having seizures. People with epilepsy, then they may have some other sort of abnormal movements. Is that part of their epilepsy? Is it something else? Then we actually admit you into the hospital, and there's a video monitor as well as the EEG running. So then you can see what's happening where the patient feels something, or when there's actually abnormalities in the EEG recording to kind of correlate between symptoms and EEG abnormalities. So treatments include the anti-epileptic medications. There's something called the vagal nerve stimulator, and then there's surgical options. So we have so many good medications for our seizures. In the past, there was just a few medications with a lot of side effects, but now we have more medications that have better side effect profiles. So that's the good news, because in terms of a lot of the neurologic problems, there's not really treatments, but for seizures, there are. And I'm just gonna skip over this because I think we're gonna hear more about that. So what is a vagal nerve stimulator? So it's something that looks like, it inserts like a pacemaker underneath the skin, and it connects to the vagal nerve, and it's thought to release currents at certain intervals that are set to help decrease seizure frequency. And this is what the wand looks like. So once it's inserted, you don't see anything, but you do feel something like a pacemaker. So with the wand, you can access the settings and change them. Like you want the frequency to be higher or lower, or you want the impulse to be stronger or less strong. So that can be all done externally with the computer and with the wand. So they have seen about 50% of improvement in seizure frequency in people who have really bad epilepsy. So in patients where they want potential, because some of these patients, they're on like 5 medications, they're still having multiple seizures a day, and they're just having side effects from the seizures, from the medications, from everything. So in those patients, a 50% reduction is actually a pretty good thing. And it can actually lead to decrease in amounts of medication that a patient would require. So in people who, when we do the workup to see if there's a specific part of the brain that could be quote unquote cut out to decrease the seizure, some people don't fall in that category. So when that happens, vagal nerve stimulation is a good option for them. So surgical evaluation, it's really, really for a specific patient, the type of mesial temporal sclerosis. So, and even the workup is very, very rigorous. It has to be localization related or partial epilepsy. So if it's involving the whole brain, you're not a candidate for surgical intervention. You have to have at least tried and failed to respond to at least 3 epileptic medications, and you have to be free of psychological disorders. The evaluation includes pre-surgical evaluation, the video EEG, neuroimaging with MRI and PET scans, language lateralization, because this is the part of your brain that controls memory, that controls speech. So they do a test where they inject Amytal and they kind of put part of your brain to sleep, and they ask you questions, and it's called the WADA testing. So they see if they take out that part of your brain, are you going to remember anything? So if it's on that side of your brain, then you're not going to be a surgical candidate. And just to briefly touch on, sometimes people with seizures are at higher risk for unexpected death. And this condition is called SUDEP. So unexpected death of someone with epilepsy who otherwise is healthy and for whom no other cause of death can be found. It is rare, but it can account for about 2% of deaths with people with epilepsy. The risk is about 1 in 3,000 per year, and it can be higher in people who have frequent uncontrolled seizures and are people who are taking high dose of medications for seizures. And this is usually later in life. It's not very common in young children.